Good afternoon, ladies and gentlemen. It is my immense pleasure to be hosting today's Meet the Expert number 9 webinar, organized by the MSc in Clinical Mental Health, run by the Psychiatry Department of the Aristotle University in Thessaloniki, and jointly with the WPA 2023 Action Plan Group on evidence-based psychopharmacology. I am delighted to have our first speaker with us, Professor Nikolaos Venizelos. He's an eminent Greek of diaspora, currently an emeritus professor and head of the Neuropsychiatric Research Laboratory and Biobank at the School of Medical Sciences at Örebro University in Sweden. He studied biomedicine at Uppsala University, and he went on to specialize in microbiology, earning a first class for his master's thesis from Karolinska Institute, titled Migration of Polymorphonuclear Neutrophils under Agarose. His career in clinical chemistry officially started in 1981 in Greece, but he was shortly appointed as a research associate at the Department of Clinical Chemistry in Karolinska Hospital, where he remained until 1997. Between 86 and 99, he was head of the section of cell culture and biobank at the Center for Inherited Metabolic Diseases at Karolinska University Hospital. At the time, his working focus was on inherited metabolic disorders, post and prenatal cellular laboratory diagnosis of rare enzyme deficiency. He received his PhD in 1997 at Karolinska Institute. And in 1999, he was appointed as senior lecturer or assistant professor at the Department of Clinical Medicine, School of Health and Medical Sciences at Örebro University. The following year, he established the Neuropsychiatric Research Laboratory, where he conducted research on the mechanisms of amino acid tyrosine and tryptophan transport, noradrenaline and serotonin in schizophrenia, bipolar disorder, autism, and ADHD. He was appointed as associate professor in 2004 in the same university when he undertook the role of program director of a 4-year undergraduate biomedicine degree offered by the School of Health and Medical Sciences at Örebro University. He served as a member of the National Council of Biobank in Sweden between 2006 and 2008. In 2012, he was appointed full professor in biomedicine and experimental neuropsychiatry at the Faculty of Medicine and Health in the same university, Örebro University. Professor Venizelos' research in experimental neuropsychiatry is focused on exploring the role of regulatory mechanisms of pro-inflammatory cytokines, lifestyle stress factors, and effects of probiotics, lithium, and clozapine on the transport of the dopamine and serotonin precursors, tyrosine and tryptophan in neuropsychiatric disorders. His prizes include the Norwich Pharmacia Award in 1994, an honorary fellowship by the National Hellenic Research Foundation in 2010, and the Delphic Prize for Outstanding Contributions to Psychiatry and Related Sciences in 2016. During 2017 to 2019, he acted as ambassador for the World Congresses of Biological Psychiatry. Of uttermost interest, however, he is the recipient of strategic funds to lead the research project Ikaria Healthy Aging, which investigates the mechanisms of healthy aging in a longevity population on the Ikaria Island. I can't wait to hear more about this project. Professor Venizelos is currently the course director and examiner for year 4 of the medical program and an interdisciplinary PhD course, and is also tutor for medical students in year 3. In addition, he has some selected lectures at the master's program in medicine. Professor Venizelos has acted as chair and reviewer for external evaluation and accreditation committees of medical schools all over Greece, in Athens, Thessaloniki, Ioannina, Patras, but also for the Swedish Higher Education Authority. He is the founder of Nobel Day festivities in Aristotle University and has organized and chaired many symposia and conferences in neuropsychiatry, contributing to over 200 papers, including original articles, reviews, book chapters, long abstracts, abstracts to national and international conferences. We are privileged to have him with us this evening, and I call for his talk, which is titled Identifying the Pro-Inflammatory Cytokines' Role in the Mechanism Transport of Tyrosine and Tryptophan in Neuropsychiatric Disorder, the Influence of the Probiotic Butyrate. Professor Venizelos, thank you.
Thank you very much, Eva Maria Chapaki. I thank the Professor Foudourakis that invited me for this session. I will now try to chair my presentation. Thank you. So I suppose I'm not supposed to talk about me because Eva Maria Chapaki have been done very well. Thank you very much. And now I just want to say that just now I'm sitting in Sweden, in Örebro, in our Örebro University, and our town Örebro, except the university, has also a castle that is more than 7 years old. Now suppose, or the meaning is to just outline evidence from in vitro investigations and concerning about the pro-inflammatory cytokines, the role, the transport of tyrosine, and of course, just mention about the influence of probiotic butyrate. So my presentation's contents will have 3 parts. Part 1, a short update of neurotransmitters precursor tyrosine and tryptophan, a schematic presentation of working hypothesis, and methodology and functionality of fibroblast model and connection to neuropsychiatric disorders, and of course, a scientific output from different studies concerning the aberrant amino acid transport. Part 2, I will try to introduce you to inflammatory cytokines, a short update and connection to neuropsychiatric disorders, and then, of course, a schematic presentation of our working hypothesis. The last of the part 2 will be, of course, to give you some effects, some results regarding effects of pro-inflammatory cytokines. And then, of course, part 3, just a short mentions about the probiotic butyrate and neurotransmitter precursor tryptophan. The neurotransmitter tyrosine is important for cognition and psychiatric symptoms. And just go to fresh up you little bit the biosynthesis, the synthesis of catecholamines, and then you see that we have the tyrosine that is metabolized to dopamine, non-adrenaline, and then is going to adrenaline. The same is concerning the tryptophan, that is a neurotransmitter important for the social behavior. It's about signaling the positive life events, has effects on appetite, sleep, and is overall metabolism, even on the activation of osteoblasts, increase the risk of suicide and relating also to aggression. And the tryptophan, 7% of tryptophan is metabolized to serotonin, and observation, the peripheral synthesized serotonin cannot pass the blood-brain barrier. And the 19% is metabolized to kynurenic acid. Now, these slides will try you to introduce to our working hypothesis. As you see to the left, we have a BB barrier, the blue-brain barrier, and this will just schematically show the transport systems. And we have transport systems from tryptophan, and then to the left, to the right, we have the tyrosine and alanine. And down you see the metabolizers with the synthesis of adrenaline. And of course, for the other side, the serotonin. Now, the classical hypothesis of dopamine hypothesis is like that. In schizophrenia, when we have an increase of dopamine and serotonin, we have a positive symptoms, delusions like that. And when the dopamine and serotonin, we have the negative symptoms. And in another case, the tryptophan, the bipolar disorders, when we have an increase of dopamine and noradrenaline and decrease of serotonin, we have a mania. And in depression, we have a decrease in dopamine synthesis, noradrenaline, and serotonin. Now, our hypothesis is a disturbed availability of tyrosine and tryptophan caused by competitive transport of other amino acids or cytokines effects or aberration in a transport across to the blood-brain barrier can distribute the dopaminergic serotonin neurotransmission in the brain. That is our working hypothesis. Now, human fibroblast is working model, data and facts. This is like the schizophrenia, bipolar disorders, autism, and ADHD have been difficult to study biologically, since this would require taking biopsies, samples for the patients and the controls brains. That is not possible and not permitted by ethics. So what the fibroblast model express? Yes, the fibroblast model express all the systems, exclude external influence of medications and other environmental factors. Human fibroblast cells and human brain microvascular endothelial cells are shown to have the LAT1 and isoformal LAT of L system as major transport of tyrosine tryptophan in common. And patient fibroblasts can be transformed into stem cells in neuron cells. Now, skin biopsies and culture is easy way. As you see, you just easy take a piece of skin, culture it, make it a lot of fibroblast cells, and then putting in minus 186 in the biobank. And then you can take up the cells, incubate it in the laboratory, make an analysis. I'm not going to tell you the details of analysis, but it's easy to make analysis. And you can measure the transport or the genetics of tyrosine and tryptophan by use labeled tyrosine or tryptophan. And of course, the Vmax, the cytokines, the Vmax and Km of kinetics, you can obtain it by use the Michaelis-Menten equation. Vmax reflects the maximum amino acid transport capacity, and Km reflects the affinity between the amino acids and the binding sites of membrane transporters. To the right, you can see how this carrier mediate transport working. These things is not new things, it's old things, it's just only to fresh up you how we're working. Now, we have characterized the major amino acid transporters and their isoform. As you see here, the tyrosine and tryptophan and alanine mainly occurs through L and A system, and LAT1 isoform is the major transporter. And here we have a picture that the LAT1, you can see that the expressing also in the vascular endothelial cells. Now, schizophrenia, bipolar disorders, autism, and ADHD show significant overlap of symptoms and treatment strategies. Some etiological is genetics, environmental, neurodevelopment facts, neuropharmacological aberrant dopaminergic and serotonergic transmission systems, immunological, pro-inflammatory cytokines. And the last two fields we have been focus our research. And this I'm going also now to show you some experimental data of experiments. Now, aberrant amino acid in schizophrenia and bipolar autism, all of this is scientific output. So, sorry. Here we have a table with scientific output, and you will see that 87 was the first experiment we do that, and we had 10 schizophrenic patients and 7 controls, and we find that the tyrosine Vmax was reduced, significantly reduced. 91 we make in Karolinska Institute in vivo studies, and we find that the influx of genetics one was reduced. In this case, we have five patients and 5 controls. 94, we just make again the experiments to see that the things is the same, or it's not perhaps some methodological role, and we find the same. But as you see, 5 patients was very little for it. And then 2000, we have 36 patients of schizophrenia and 10 controls. And in this experiment, of course, study, we find both Vmax and Km that was reduced. 2007, we was testing our model to autism. We have 11 autistic children and 11 controls, and we just measure, controlling the tyrosine and alanine. And in this case, we find that the tyrosine, the Km was reduced, but we find that the alanine transport was increased. 2009, we just proved the bipolar disorders patients, 11, and we just measure the tyrosine, and we saw that the Vmax was reduced. 2011, we just make again schizophrenic, 13 schizophrenic patients, 20 relatives to the schizophrenic patients and 10 controls. And also here we find that tyrosine was reduced, both the Km and Vmax. And 2011, of course, we are testing the model with ADHD patients, and in this study we have testing both the tryptophan, alanine, and tyrosine, and we find that tryptophan was reduced both in Vmax and Km, but alanine was increased as in autism, and we don't know what the role of alanine still of this. And of course, 2018. We just test the system in myo patients, in patients with osteoporosis, the men of patients with osteoporosis, in the 14 of these, and we find that tryptophan, it was reduced. So this is what we find as scientific output. So the synopsis of this, let's say, experiments or studies is that that the studies suggest that we can have a limited access or availability of the precursor amino acid tyrosine and tryptophan into the brain, which could lead to imbalance in central neurotransmitter systems. Now, we are going to the section 2 with cytokines and CNS. As we know, the cytokines is proteins, signaling molecules, and together with semokinase are the immune system's core, watching intensive when the immune systems found something which needs to be addressing to either fix it by itself or communicate into the other cells or mediators, perhaps also to the brain. Communication is the key, and it is suggested that the signals reach the brain, essential to the system to work. Taxonomy after the function or after their reports, we have about 17 different cytokines. What we know about pro-inflammatory cytokines such as pro-inflammatory EM-beta, IL-6, TNF-alpha, and EFN-G, gamma, by signals affect the central nervous systems and the hypothalamus, resulting in symptoms such as fever, anorexia, dyspepsia, fatigue, loss of appetite, and interest of the outside world, and cause, of course, pathological pain. These symptoms are also the central psychological and social stress, as you already know. This regulation of pro-inflammatory cytokines have been linked to depression and other neurological diseases and are activated by mental illness. For instance, interleukin beta is mainly activated in schizophrenia and bipolar disorders, and IL-6 in depression. IL-6 play a role in neuronal reaction and damage. TNF-R is present in neurons and the glia, and often involved in regulation of apoptosis in the cells. Pro-inflammatory cytokines are involved in tryptophan and kynurenine pathway. It's just to show you what we know about it. As you see here to the right, so IL-beta can also alter in microglia or astrocytes, and then just have some effects in tryptophan and kynuretic acids. Peripheral pro-inflammatory cytokines communicate with the brain. We have a lot of publications about it. And yeah, there are evidence that the peripheral pro-inflammatory and can communicate with the brain, as I mentioned before, probably via microglia here, leading to production of more pro-inflammatory interleukin cytokines. Of course, this can have some mediate cognition effects on cognition and emotion. Now, we have an involvement of IL-6 at fibromyalgia, myalgic encephalomyelitis, fatigue syndrome, decrease in mental energy, and of course, sensitive bowel use with depression. So, except that other similarities between them, so the main connection with them is the increase of IL-6. Public utility scientific output, according to the Patients Association for EME patient, is at least 40,000 patients plagued by these disorders only in Sweden. These symptoms are so-called cognitive insufficiency, which is available on the number of other disorders like ADHD, schizophrenia, chronic depression, and chronic fatigue syndromes. The diagnoses are neglected as well as the treatment of this patient population, which leads to great suffering and alienation. So this is, of course, so the psychiatrists, the therapeutic out has perhaps to look about it and to test these patients before. Synopsis. The pro-inflammatory cytokines are associated with many variety disorders. It is obvious that this is involved in many neuropsychiatric disorders. So we expanded our study and explored the role of cytokines on neurotransmitter precursor tyrosine and tryptophan in our fibroblast model. And here it's just only a picture again, is many things. I'm not going to very details, but I want to introduce you to understand our working hypothesis. To the right, we have a model that will be the CNS. We have all of the systems that we've been talking before. Here we should have the transport systems and the BB. And then to the left, of course, we have a lot of stimuli as a mental and physical stress, somatic disease, trauma, bacterial or viral infections, and improper nutrition that we are talking very much now in these times. This, of course, alter cytokines and CL1 beta. And this, of course, then after all, by other factors signaling to the cells, macrophages and other peripheral cells, and they are promoted and then increasing and produce more cytokines. For instance, EL beta 1, EL 6, and TNF. This, of course, was our hypothesis to test in our system to see if they had effects in tyrosine and tryptophan, and then connected it to the brain. Of course, these stimulus can also have effects in astrocytes and microglia cells, but I don't have any data by our laboratory or other data, so I cannot say how much if we have the same effects or not effects. Now, our study design about the cytokines, it's the same as really we have a fibroblast, healthy controls that we have been treated with plus minus inflammatory cytokines. And of course, they are combination and testing also oxidative stress by stress the cells with peroxide and analyze the uptake of tyrosine and tryptophan. It is the same method as I showed you before. Sorry. And here we have some results. As we see here, what we find is that all the cytokines, both EL beta, EL 6, and TNF alpha, except the last one, have effects. And of course, EL beta reduce up to 47% the in-transport of tyrosine. Here we have the EL beta, but we're putting in combination with the other, TN alpha or EL beta with this. And as you see, also decrease significantly the tyrosine uptake comparing to the controls. So here we have the statistical, yes, power and significance of this. Here we have the same experiments, but it is the EL6 with the combination. And here we see very clear that when we put the TNF factor in together, we incubate the cells together with 6, so we find and absolutely higher degrees of in-transport of tyrosine. And here I just give you a synopsis of the effects, as we'll see. So we have the cytokines to the left, and we have the inhibition to the right. And we see that EL beta inhibit about the 47% the tyrosine. When we combine it with TNF alpha, so we have near to 50%. And then 36% with gamma. And then all of this, of course, we go to 38%. And EL6, of course, when we take with TNF alpha factor, we have about 28% inhibitions. Now, when we just stress the cells with peroxide, so we find a decreasing of uptake of tyrosine, and this decrease is a response, by the way, to the hydrogen peroxide. we have been tested many different things with it, and we see that is test. I mean, this of course make that the cells producing cytokines, but we have not measured the cytokines in the medium. So all of these last results have been published in neuropsychobiology. Now, influence of pro-inflammatory cytokines uptake in tryptophan. Here you see we have make the same experiments as the tyrosine, but we have as a precursor the tryptophan. And you see we have exactly the same effects, both for EL-beta and EL6. This is still unpublished results, so I'm not going to talk too much, but it seems that we have the same effects in tryptophan as tyrosine. And actual unpublished results, it's that we now test the system by incubate the cells with clozapine and lithium to see what happens. And of course, we have been seeing that the tyrosine uptake by lithium is reduced a little bit, but clozapine is increase the tyrosine transport. And this is 5 minutes incubation with the cells. When we incubate the cells with 6 hours, we see the same phenomenon. Here we see that the controls is not happen much, but it's happened with the control, with the bipolar patients. So when we put the clozapine, we have effects in the transport of tyrosine in patients, not in clozapine. And the same is when we just incubate the cells of the patients, and the controls is 6 hours. So we'll see here, we have also, this is a significant, this is not significant between we have not significant between the controls and the patients. And here, it's an experiment that will be done, is to combine, to stress the cells, to make inflammation to the cells, and then put, of course, lithium and clozapine, and the combination of it to see what happens. And then as you see here, what we find is that it's happened a lot of things. Clozapine, it's increase, but not the patients. It's happened not in the patients. Here we have an EAB, the same, let's say, antagonist to the EL-beta, and we see that antagonists take away the effects of EL-beta, but not little bit, very little bit, not significance in patients. So this, of course, our preliminary, let's say, synopsis is that the clozapine and lithium normalize aberrant tyrosine uptake in bipolar patients, but have no additive osteogenesis effects. It's about the mechanism of pharmacology in these experiments. Now, this, of course, is the same picture, but I want to say you that after our hypothesis, working hypothesis, we find that really these cytokines inhibit the tyrosine and tryptophan transport about to 75%. And then we suppose that the same can happen in the brain, in the cells and brain. Conclusion and diagnostic care is that the pro-inflammatory cytokines, EL-beta and 6, that are elevated in schizophrenia and bipolar are critically regulating the availability of transmitter precursors tyrosine and tryptophan. Cluster analysis that include the measured biomarkers allow stratification of major psychiatric disorders. Therapy can assist to a more correct diagnosis and personalized medicine. And now I'm going to the last part, suggesting butyroate testing to be a key of mediator in the gut-brain interactions. Here we have the model. And of course, we know that butyrate is a short-chain fatty acids metabolite producing in microbiota in the colon. Its antioxidant property suggested to be a key mediator in the gut-brain reactions, has been shown to alter the neurological functions in the neuropsychiatric disorders models. This is our working hypothesis. To the left, we have fibroblast cells, healthy individuals. We just incubate with butyrate 20 and 40 millimolars. And then, of course, plus minus hydrogen peroxidase, that stress the cells, and then measure the tryptophan uptake. And we see to the left here, we find that butyrate increased the uptake of tryptophan in fibroblasts. Here we have the control with 20 megafractions increase, and then of course 40 increase, much more. And here we have the butyrate that incubate with different with peroxidase, yes, peroxide. And as we see here, we just have the peroxides, it's going down significant. But when we put the butyrate is going up, and then of course when we go for 1 hour, when we put 40 millimolar butyrate, it's significant going up again. So what to show here is that butyrate counteract the oxidative stress in inducing abnormal tryptophan transport, and subsequently restore the abnormal levels of tryptophan precursor of serotonin. Synopsis: the oxidative stress led to decreasing transport of tryptophan into fibroblast cells, which could indicate that oxidative stress may cause abnormal tryptophan transport across to the BB barrier and could distribute the levels of serotonin in the brain. Butyrate at different concentration was found to restore the tryptophan transport in oxidative stress in fibroblasts. And thank you. These people have been all the time working in the lab and contributing to all of this research and results that I have been just present to you. Thank you. So I leave to Eva Maria Tsapakis.
Thank you very much, Professor Venizelos. This was an exciting tour de force. And it's so interesting always to see the basic pharmacology being linked to clinical psychiatry, to our everyday life, and you know, in the search of bettering, of improving the lives of so many people. How do we measure pro-inflammatory cytokines in vivo? Are they easy to measure assays?
You mean we're not measuring, we are just putting.
You are doing this in the fibroblast model, but
yes,
I'm just wondering if we wish to study pro-inflammatory cytokines in vivo, would they be a biochemical test in a test tube?
Yes, there are biochemical. You have a cheat that you can measure it. You see, to measure the cytokines in the blood, let's say I have to find some slides to show you a little bit. Please wait a little bit. Do you see these pictures?
Yep.
Yes. Look, to find the cytokines, to measure cytokines, you have to do that because it's about 6 hours, 3 hours in the blood. Only in the chronic infections, inflammations, you can have the cytokines in the blood. In other cases, you cannot measure it. So you have to measure it under the ongoing inflammation.
Okay.
So here you see the picture, what you can do that. How many hours after that you do that? Because the first cytokines, they are producing to the peripheral cells.
Yes.
And of course, when this is a chronical, it's a lot of cytokines, they are just coming to the blood circulations. But if it is the inflammation is very, very short, perhaps you cannot find these cytokines in the blood.
So timing is a factor that has to be taken into consideration when measuring them.
Yes. So when you have the patients, it's acute when you see that you have to look a little bit. If you have an ongoing inflammation, you have to take and to measure this time, because if it is after days, so perhaps you cannot find the cytokines. It's only when we have, let's say, if we have a chronic depression, it means that you have all the time ongoing produce of the cytokines in peripheral cells. Mm-hmm. In this case, so we have all the time that the cytokines is coming to the blood circulations, and of course to the perhaps it's coming to the external fluid of the cells, that they can have this effect to the transports.
I see.
Extracellular liquid at least, so you can.
I have one more question, but I was wondering whether there are any questions from the floor, from the audience, before I fire mine.
Yes.
Our participants can always use the chat function to send us questions, or if they wish to clarify a couple of points. Okay, well, I've got a question, and it's also I would like to hear more about the Ikaria project, and tied to this project, I was wondering, would a tiny bit of lithium in our water or clozapine in homeopathic doses be beneficial for our longevity?
Perhaps. It's not easy to speculate on this. It's not easy. So in this case, I have only to let's say, to present the experimental data I have.
Sure.
In other case, it's a lot of speculation, and I don't want by any way.
No, I'm sorry. It's an unfair question, but one wonders, because normalizing the aberrant tryptophan or tyrosine uptake would certainly lead to better neuronal connectivity and neurotransmission. So one wonders. There is a lot to be done, I'm sure, in the field. But please tell us a bit about the Ikaria project.
Yes, what Ikaria is that as I mentioned before to you, that the depression in Europe, in England, it's about 60%. Yeah. And in Holland is about 40%. In Mediterranean countries, about 20%. This is, let's say, information with Sir Mori, the guru psychiatrics from England. Now, what is from my side is that I know that if you have a depression, let's say I will do that a little more experimental. In Sweden, we have about 500 suicide with old people. And of course, as you know, it's not because these people is poor. In Sweden, even if you have not working, so after you are coming up to the 65 years old, so you get money enough to live. At least is about 800 euros in the month. And then if it's not enough, you can have more, let's say, money to have a good life. But of this case, we have still 500 suicide in Sweden. And I think the main thing that is the depression is the chronic depression. Chronic depression, it means that you have not the good social, let's say, life. You are closed and living alone. You are taking a lot of medication just to feel good. You are not eating good. You are perhaps drinking. You are not sleeping good. What you do that is that you just have a chronic inflammation in your peripheral tissues that from my side perhaps produce a lot of cytokines. And then if you have already something you see not good in the brain, plus when what I have been shown to you, if you have a lot of inflammations, so it means that you reduce your life. You make, so that was, and then I find in Ikaria, people that are in age more than 80, up to 103 and 109, that they are very happy. They are not rich, they are poor. They have been poor all their life, but they are happy. And it seems that they don't have any depression. So perhaps one of the key of the life, I mean the good life, let's say healthy aging, is perhaps to look the depression. I'm looking about it. We have been looking about the 50 cytokines, but still we have not results about it. It's coming. Yes.
We'll be here and waiting.
We have been looking about their ophthalmological, and then still they are very good. It seems that we don't find, we have not published it, but we did not find any, let's say, let's say ACE disease that are relating to diabetes 2, and many other things. So it is, of course, very, very important to see what we find and to correlate, of course, in genes and physical activity. We have a physical activity, and of course the food, because if we are talking about the probiotic butyrate, so we are calling about the food. Perhaps the food, it's special. Perhaps microbiota that produce a lot of probiotic, you see, butyrate like that. That is, it's good, healthy for the brain. I don't know. We'll see what happens. But it's very important. By say it's to see what happens with these people. Yeah.
Wonderfully interesting. It's very, very interesting.
And then I said to you that we have a correlation between the short and the life.
Yes, I think we should all hear about this. short height and longevity.
Yes, yes.
God knows what, you know, we're waiting to see the evidence for that.
We see 2 years evidence. Yes, yes.
Yes.
We are now looking and try to analyze. Or we have about 220 proteins to look, and then to look what the function in the cells and what this has to do with the life, with their life. I mean, in the brain, you see. But I'm still very interesting. I think that the brain, it's if you wake up the brain, so the brain take care of you, take care
Yes.
to repair the cells.
To repair the cells.
Yes, and like that.
Yes.
So this is theory. We'll see what happens.
Okay, we'll wait to see the results. I've got one question from one of our participants, Mukesh Ambwani, who writes, thanks to Professor for wonderful talk. Is there any role of anti-inflammatory to decrease cytokines level in chronic depression along with antidepressants?
Can you repeat it, please?
Yes. Is there any role for adding anti-inflammatory medication, I guess, to decrease cytokines, the level of cytokines in chronic depression, in addition to antidepressant therapy?
You see, I can say I can go again to the food.
Mm-hmm.
If you, I mean, we have to try to these people first to give, let's say, to make a kind of treatment if they have cytokines,
Mm-hmm.
the usually treatment, and then to combine it. Of course, we have not to change the medication, the usually medication, by to prove first to treat the inflammation. The inflammation is one to prove it, perhaps vitamins, butyrate. Now you can have it, or to give. You see, you can find a lot of tryptophan, tyrosine in good food. You see, nutrition. So I will say like that, to give the patient first to have a good nutrition, special nutrition. So to have, let's say, to have a lot of tryptophan and tyrosine in the body, you see. So, and then to treat them, the inflammation. Together with the treatment or the usual treatment, perhaps this can make better them.
Yes.
That is my mind. It's a combination of three.
Clear and very promising, because nutrition plays such an important
I don't know,
role.
but you have to prove it.
Yes. Interesting. Okay, well, thank you very much, Professor Venizelos. This was a great tour de force, a live tour of your research, and it's very enlightening both for basic scientists and clinicians. And as you say, it remains to be proved in real clinical settings, but we're here to take it to take the lead. So thank you very, very much for being with us tonight, and we look forward to hearing more of your data in the near future. Thank you.
Thank you very much, you.
Thank you.
Thank you.
I will now turn to our second lecturer tonight, a very dear friend and mentor to me, Professor Frank Tarazi. He's an associate professor of psychiatry at Harvard Medical School and director of the Laboratory in Pharmacoeconomics and Health Outcomes at McLean Hospital. He is a preclinical and clinical expert on Alzheimer's disease, Parkinson's disease, schizophrenia, depression, and ADHD. Dr. Tarazi has published over 120 original articles and reviews in highly cited scientific and medical journals. He has also published over 12 book chapters, including a chapter in the standard textbook Goodman and Gilman's The Pharmacological Basis of Therapeutics, and co-edited a book entitled Neurological and Psychiatric Disorders from Bench to Bedside. Dr. Tarazi is the Associate Editor of Pharmacology and Therapeutics and CNS Spectrums, and serves on the editorial board of several other journals. He is a fellow of the American College of Neuropsychopharmacology and a member of the American Psychiatric Association and the American Academy of Neurology. He is also a member of the World Economic Forum's Global Council on Neurotechnologies and Brain Research. Dr. Tarazi's Laboratory in Pharmacoeconomics and Health Outcomes has a long-standing interest in understanding the pathology and neurobiology of neuropsychiatric disorders. The program focuses on clarifying the mechanisms of brain plasticity, gene expression, and responses of cellular elements to different psychotropic drugs, and has identified several novel brain sites and pathways to constitute attractive targets for new drug development. Dr. Tarazi and his group have also established several animal models that provide close presentations of the core symptoms of neuropsychiatric conditions, and have efficiently utilized these models for assessing the actions of standard and experimental medications. He has been awarded research funding from NIH, NARSAD, the Stanley Foundation, and from several pharmaceutical and biotechnology companies. The mission of the program is to continue discovering additional translational principles that provide new insights into the neurobiology of neuropsychiatric disorders, as well as developing much needed novel drugs that are effective in managing these diseases with superior safety, tolerability, and long-term maintenance. He has extensive experience in the design and execution of clinical trials on psychotropic drugs, and has participated in the preclinical and clinical development of several antipsychotic and antidepressant drugs, including aripiprazole, brexpiprazole, iloperidone, asenapine, vilazodone, atomoxetine, and cariprazine. He is an expert on the economics of psychotropic drugs and on the mechanisms of action of antidepressant and antipsychotic drugs, as well as on how the neuropharmacology of psychotropic drugs can translate into therapeutic advantages, including efficacy, safety, and tolerability. He has received several awards, including the A.E. Bennett Award from the Society of Biological Psychiatry, the Rafelson Fellowship Award from the Collegium International Neuropsychopharmacologicum, the Geordie Folge Pye Memorial Award from the American Society of Neurochemistry, the Alfred Pope Award from McLean Hospital, and the Dean's Dissertation Award from Rutgers University. I'm honored to have been his research collaborator since 1997, when I first joined Professor Baldesarini's laboratories at McLean Hospital in Belmont, Massachusetts, as a medical student. Ever since, I have enjoyed Professor Tarazi's mentorship, both in molecular psychopharmacology research in his rodent models of disease, and more recently on the pharmacology of novel antipsychotic and antidepressant compounds, including the use of psychedelics in PTSD, among others. I'm truly honored he is with us tonight, and I thank you for being here. He's going to talk on a very hot topic, immunotherapies for Alzheimer's disease. Are they ready for prime time? I can't wait, Frank. Thank you.
Thank you, Eva. Thank you very much for this lengthy introduction. Appreciate it. Basically, you summed up all my professional history in 10 minutes. Great. So again, thank you, Eva, very much for this wonderful presentation. It's also, for me, it has been a wonderful and a pleasurable experience always to interact with you and discuss things and research of common interest along the years, of course. So I'm going to be talking today a little bit different on Alzheimer's disease and what are the new therapies that are now in the pipeline that appear to be promising at least to fulfill a major gap or unmet need in the treatment of such a devastating disease that affects not only patients, but also their families and caregivers. And my title will be Immunotherapies for Alzheimer's Disease. And the question that I propose, and hopefully by the end of the talk, we will be able to answer it, are they actually ready for prime time? What is Alzheimer's disease? And as you see here, just among the symptoms that we will discuss, Alzheimer's disease is a disease typically affects the elderly, and it starts with behavioral changes in these patients. So they will start difficulty remembering events. They will start having problems in terms of repetition of the same question. They all will start repeating the same question, every 10, 15 minutes. Without recognizing that they have just asked this question, and without understanding that this question has been answered before. Every time for them, it's like a new experience when they ask these questions. We have no idea of recollection that this question was asked and was answered before. Then we will start seeing, issues with short-term memory, so problems with remembering faces, names, misplacing items, misplacing keys. And they become also, there are some mood swings in some of these patients that they are no longer family will recognize that this is not the same person that they used to know. They will start also forgetting specific events like anniversaries or birthdays that they did not forget before. They will have issues in their speech. How cohesive is the speech? You will find them, talking, but then they jump to other topics without even noticing that there is no connection between what they were talking about a minute ago and what they are going to talk about. So all these things become, and the problem is that they start getting worse. Alzheimer's is a disease that is progressive in nature, and it gets worse by time as the disease progresses and the symptoms get worse. So how do we, where do we find what is the best way to treat these patients? And typically, ideally, these patients can be and should be treated in what we call memory clinics. And these are clinics that are specifically have a team members, a group of experts, of specialists in different disciplines that can provide the best and the most optimal therapeutic treatment for these patients. These memory clinics will have a neurologist, a psychiatrist, a neuropsychologist, and they will have access to imaging technologies, as well having also access to lab for doing blood chemistry. Now, how do we actually diagnose Alzheimer's disease right now? You can still, till today, to a great deal, we do it by the process of elimination, trying to eliminate other conditions that actually can have overlapping symptoms with Alzheimer's disease. So first and foremost, we are going to look very carefully at the history of the patient and the family history, whether these dementia disorders, especially Alzheimer's, have been reported previously in parents or grandparents or siblings or relatives. This is important to know whether it's familial or whether it's sporadic. Then we do the general neurological examination, general psychiatric evaluation, and specifically we look at sleep disorders, because many times we see that these patients do have some sleep disorders like sleep apnea or other types of sleep disorders that can more or less, because they are not sleeping well, they may very well have excessive daytime sleepiness, which will affect their concentration and their cognitive function. Then, with the help of a psychotherapist and neuropsychologist, we will do the different behavioral tests that will assess different domains of cognitive memory and executive function. We have also to do a brain MRI at baseline to rule out any kind of structural changes in these patients, things like, tumors or any kind of damage that can result in these symptoms, or even cancer. So at least this will help us to exclude other conditions which can lead to these symptoms. We also do blood tests, especially like the TSH for the thyroid, vitamin B12 and lead, because deficiency in vitamin B12 has also been linked to symptoms that are similar to Alzheimer's in terms of memory impairment and cognitive dysfunction. I'd also like to do urine analysis, especially for women, because there is a high risk of UTI or urinary tract infection, when in some cases can lead to confusion or worsening of symptoms. Then we do chest X-ray as well, and PET scan or spinal tap. So as you see here, it's not easy to diagnose patients with Alzheimer's in a short visit. we put really the pieces together, and we try to come out with a definition based on all these symptoms. And most of the time, really, we say it is dementia disorder, being, of the Alzheimer's type. As you know, and dementia is like the bigger umbrella that we have. And under dementia, we have 4 or 5 types of dementia. So Alzheimer's remain the major subtype of dementia, where 75 to 80% of the cases are typically of Alzheimer's type. Then we have FTD, frontal temporal dementia, vascular dementia. We have Lewy body dementia, and we have Parkinson's disease dementia. So by excluding other conditions, by excluding other disorders that may have overlapping symptoms, we can come, and by excluding biochemical reactions that can, more or less show that deficiency. So if a patient, for example, has vitamin B12 deficiency, I will try to correct for this deficiency by giving exogenous vitamin B12, and may very well this lead to improvement of the symptoms. The last one I mentioned, PET scans, and specifically now for PET scans, we'll be looking at accumulation of a specific protein that's called beta amyloid. And now we have 3 different ligands that through positron emission tomography, the most famous one is the Avidit compound that is developed or traded by Lilly. And as we see here, this is a negative scan, and in Alzheimer's patients, definitely where the red is more darker or higher levels of expression, there are higher, as you see, higher levels of expression of beta amyloid. So it's very sensitive, the system here. Higher levels of expression of beta amyloid in the brains of these patients. So this is additional indicator that, by putting all the tests that we have put together, validates that what we have here, coupled with impairment in the behavioral symptoms of the patient, can further improve or confirm that it is the diagnosis of Alzheimer's disease. If PET scans, these are not accessible everywhere. They are also very expensive, and most of the time they are not covered by insurance. And so there is still the prospects of doing a CSF sample, where a sample is collected from this cerebrospinal fluid, and then these patients are going to be looking at specific signatures, what we call in these samples, that there will be reduction in A beta 42, there is increased phosphorylated tau and increase of total tau, as well as an increase in what we call NFL or neurofilament light. And neurofilament light is considered a non-selective biomarker for neuronal damage, and an increase in NFL, though it is not selective for Alzheimer's disease and has been also used as a biomarker for other disorders, is still an additional piece of information that is valuable to further confirm the diagnosis of Alzheimer's disease. So if we, the treatments for Alzheimer's that we have right now are fairly limited. We have, acetylcholinesterase inhibitors, the donepezil or Aricept by far is the most famous one, you can say, and widely used. We have rivastigmine, also, or excellent patch that comes in a patch, which can be useful in some patients who have problems in swallowing. And then, typically patients will start on a dose of Aricept of 5 milligrams for 1 month. Then we increase the dose up to 10 milligrams. And then after, the benefits of Aricept are relatively short in duration. So after a year or 18 months, the effects will start to wear off. In this case, I will add the second drug that is approved together with Aricept. It's memantine or Namenda. And, that's basically what we have in terms of pharmacotherapy. Now, there is a Nozamric, which is a combination of donepezil and memantine. This just, is a same pill containing the 2 drugs, donepezil and memantine, and is provided just for convenience for treatment of patients. So if we look at the cellular or the molecular level of these, of Alzheimer's disease, I can tell you that, that is still the 2 main hallmark of the disease is the accumulation of the amyloid plaque and the fiber tangles. So the plaques and the tangles remain till now as being the main pathological, hallmark of Alzheimer's disease. And so in this case, we have if we look at it, that this is aggregation of beta amyloid. We have the monomers. Something goes wrong with the processing of the APP, amyloid precursor protein. And as a result, these will start aggregating together as monomers, and they become oligomers. And these, when they become oligomers, they start aggregating together. And when they do so, they will start forming these big plaques, and these chunks of toxic proteins will start blocking the activity of other cells and enzymes that are essential for cell survival and functionality, leading to synaptic dysfunction and eventually leading to cell death, and through the activation of the microglia. The other pathway that has been targeted is through the tau. It's another, the protein that is essential for microtubule stabilization. And we see also that these tau proteins will start overexpressing themselves, especially the phosphorylated tau, forming aggregates, which eventually will lead into the formation of the tangles, and we'll see a similar cascade of events that will stimulate neuroinflammation, synaptic dysfunction, and eventually result in neuronal death and the manifestation or the development of symptoms of Alzheimer's. So the goal right now in Alzheimer's is to try to develop therapies to prevent this accumulation of either the amyloid plaques or the tangles through the aggregation of the tau. So, there are different approaches that have been tried in the clinic. One approach is basically to block the aggregation this way, at this stage, which is prevent the abnormal expression of A-beta using what we call the BACE inhibitor, or inhibitors of the enzyme that will break down the APP and lead to the formation of A-beta. Unfortunately, this approach was not successful enough because we have seen that many of these patients start developing side effects, peripheral side effects, especially liver toxicity, since you will be also blocking the activity of the BACE enzyme in other organs, peripheral organs like the liver. And so we don't, this approach was not successful. And so we moved on to the second approach, which is try to develop monoclonal antibodies specifically raised against these plaques or against these tangles, and try in this way that these antibodies will bind to these plaques and try to clear them from the brain by, perhaps carrying out from the brain into the CSF. So the advantage here, it is specific in nature. The target is very specific. These monoclonal antibodies were raised against specific epitopes within the plaques. So in this case, you don't have to worry about binding to non-specific sites in peripheral organs, like what happened with the BACE inhibitors. And this could be more or less an effective approach towards developing new therapies, because if the clearance of the beta amyloid is one of the factors that lead to the improvement of the behavioral symptoms of Alzheimer's, then the use of monoclonal antibodies can be the most selective and perhaps the most successful approach in the treatment of the disease. So, and in this regard, we start seeing companies trying to develop their different monoclonal antibodies, though these all antibodies actually do target the same protein. They were raised against different epitopes within the same protein. But as you see here, these are the antibodies that will try to come and bind to the toxic protein beta amyloid and try to clear it from the brain. And the first one that attracted most attention to the level that even it was approved is aducanumab, and that's the one that we will talk about in details, because I think this is the one that opened the door for other antibodies to continue in development and perhaps be, as we'll say, more superior than what aducanumab is offering now for our patients. Aducanumab is a monoclonal antibody that is developed by Biogen. And again, as we see here, they're trying to bind to the oligomers and in a way that will prevent their aggregation and their accumulation. And specifically, the way it was designed, it's to be selective for the A-beta aggregates and prevent their accumulation and blocking the activity of other enzymes and proteins that are essential for cell survival. So it basically reduces the formation of this neurotoxic A-beta oligomers. And Biogen conducted 2 clinical trials. They were more or less carbon copy of each other. They named the first one the EMERGE trial, and they tested 2 doses of aducanumab. One is 3 and 6 milligrams per kg, and one at a higher dose of 6 to 10 milligrams, and they had a total of 1,600 patients. These, as we just look at their baseline, they were more or less double-blind placebo-controlled trial that lasts for 18 months, 78 weeks. And what I want to say is show that these patients all had abnormal accumulation of PET at their baseline. And as you see here, the demographics of these patients were equally to a great deal randomized among the three arms to minimize for any variabilities that may result from the differences in their demographics. If we have different scales that we can assess the behavioral symptoms of the disease. And perhaps the most famous ones are what we call the CDR-SB, or the Clinical Dementia Rating Scale, sum of boxes. And as you see, the three groups have score between 2.4 to 2.7 to 2.5. At least when looking at this score, tells me that these patients are in the mild phase of the disease. And not that the disease did not progress and reach moderate or severe. They are all within either what we call MCI, mild cognitive impairment due to Alzheimer's, or they are in the mild phase of the disease. The other also scores are in agreement at the ADAS-Cog13 that all these patients are in a milder phase of the disease. And that's why we think that intervention at this stage may provide more therapeutic advantages and better outcomes in terms of management of the symptoms of the disease. So if we see here, the change on the CDR, we found that, after 78 weeks of treatment, there was an evidence that aducanumab was able to reduce the decline in cognitive function, memory, and executive function by 22%. As I said, and it was clinically significant or statistically significant. This was only seen with the high dose of aducanumab. The lower dose between 3 and 6 was not effective enough. Then the other scales also showed similar benefit in terms of the ability of aducanumab to reduce the decline in cognitive function in Alzheimer's patients by 27%. This is another scale that is also used frequently in clinical trials to assess the benefit of the treatment on the behavioral symptoms of Alzheimer's, including the cognitive, executive, and memory functions. ADCS is a very valuable behavioral scale that we use to assess the functional activity of the patient. This is also very important, not just for the patient, also for the caregivers and the family members. How is this patient, able to function on daily basis? Is he able to be independent, to dress alone, to walk alone, to eat alone, or will he still need support and help? And there we saw the best, outcome that the aducanumab was capable of reducing the decline in functional activity of these patients by up to 40%. So all these endpoints have shown us that there is, based on two scales that we have used, there is some decline in the slowing the decline in executive, cognitive, and memory functions. And this was reflected in the improvement of the daily functional activity of patients. That's all behavioral analysis. So what now at the level of the molecular level, what happens actually in terms of the biomarker we're going after? And this, as you see here, studies with, after 1 year of treatment with these patients with aducanumab, this is the baseline of these patients at the different doses. And as you see, there is significant accumulation of beta amyloid, the one at baseline on the left. After 1 year of treatment with the aducanumab, we see significant reduction in beta amyloid in the brain. So this is valuable because it does validate the concept and the engagement of the therapy with the biomarker of interest. This disease-modifying therapy really counts on changing the levels of beta amyloid in the brain, and then you hope that this will translate into improvement of the behavioral symptoms of the disease. So in addition to validating the behavioral effects of the therapy, I think it's also important to validate that this therapy is engaging with the target of interest, and it does cause reduction in beta amyloid, which is the main target of this therapy. And as you see here, if we compare after 1 year, profound reduction across the different doses. Perhaps the most that we see is with the highest dose of 10 mg per kg, in these patients, profound depletion of beta amyloid. And this was also reflected in the, as we see here, that even we start seeing the reduction as early as 26 weeks and was significantly and profoundly achieved after 78 weeks. So as you see here, it's the reduction in beta amyloid in this specific trial did translate into improvement of the behavioral symptoms of the disease. And again, they show also that with CSF, with tau, at this stage, we did not have a ligand specific for tau to do PET scans, though this ligand now is available and will be used going forward in clinical trials. But when they did the analysis of the CSF, also there was a reduction in phosphorylated tau and in total tau at the high doses of aducanumab. It's important to see that these therapies also do carry higher risk of what we call ARIA, or amyloid-related imaging abnormalities. And what we have seen is that, the incidence of ARIA was around, especially ARIA edema and ARIA hemorrhage were 35 to 20%, but most of the patients did not have symptoms. These were asymptomatic, that they were detected during frequent MRIs. And most of them also resolved within 4 to 16 weeks without having long-term benefits. So still, this is not a simple therapy. This is still considered invasive. You are introducing a foreign body in the brain, and the brain will recognize that this is a foreign body and will start what we call the mechanisms of repulsion or exclusion outside the brain. And by doing so, will stimulate the mechanisms of neuroinflammation, which can lead to these symptoms that we see with MRIs, like edema and microhemorrhage. Then this was one side of the story. Let's look at the other trial that they also did, the ENGAGE trial, which, as I said, it was completely, carbon copy of what was presented in the EMERGE trial, even in terms of the number of patients, around over 1,600, and the doses that were used in the two trials. Now here we get a completely negative outcome, which was really disappointing, because on all the endpoints that were met in the EMERGE trial, they all failed to meet in the ENGAGE trial. And as you see here, even with the high doses on the CDR-SB or on the ADAS-Cog, basically there was no change from the placebo arm, and which was really disappointing. So regardless how we look at the ENGAGE trial, it is considered a failed trial, what we had is two trials. One was successful and one completely failed. So was left up to you. Do you want to look at the glass half full or half empty? Regardless, the two trials, though they were similar in terms of the randomization of patients, the number of patients, one was successful and one failed. The only thing that these two trials agreed upon is the ability of the antibody to reduce the levels of beta amyloid using PET scans. And this was consistent, and with the significant and profound reduction in beta amyloid as early as 26 weeks and all the way up to 78 weeks. So they agreed on their ability to engage with the biomarker of interest. They disagreed on their ability to improve the symptoms of the disease on the different behavioral endpoints that we typically use to assess the efficacy of drugs in clinical trials. They also agreed that both were successful in reducing tau pathology. So in this regard, we see an agreement on terms of the biomarker engagement. What we fail to explain is the failure that both should have seen. Since we are in agreement and engaging with the target biomarker of interest, we should have seen perhaps comparable outcomes on the behavioral symptoms, something that was not replicated in both trials, which left us with a question mark about the effectiveness of this drug as an effective therapy to improve the behavioral symptoms of the disease. Nonetheless, the FDA, with a surprising decision, did approve aducanumab on June 7th of last year, and they gave it the name Aduhelm. And, regardless of the FDA decision, this became the first drug to be approved for Alzheimer's in 18 years. 18 years, so the last one was Memantine or Namenda in 2003, but it is now considered as the first disease-modifying therapy for Alzheimer's. And all other therapies that we discussed do not slow down the progression of the disease. They are not considered disease-modifying. This one met the criteria through its engagement with the biomarker, beta amyloid, that it can be defined as a disease-modifying therapy. The interesting thing that the FDA used what we call the accelerated approval program to approve this drug. And this is, basically says that the drug will be approved that for conditions that are serious, they fill an unmet need, and there is no effective treatments for this condition. And usually the approval really was based on the changes in the biomarker, the ability of aducanumab to reduce the levels of amyloid plaque in the brain, which typically is not something that is a pathway that is used to approve drugs for neurological disorders or psychiatric diseases. We still count on the improvement of the behavioral symptoms. The accelerated approval program is more used in oncology for approval of drugs for different types of cancer, especially the new immunotherapies that more or less count on these biomarkers as a valid indicator to base a sound judgment to use the therapy or not based on the levels of this biomarker. So here we have, a novel approach that was more or less, novel to all of us, and we were surprised that the FDA took this program or accelerated pathway to approve the drug. But then they also said that this is more or less a conditional approval, that Biogen still has to conduct a phase 4 trial with significant number of patients to verify the clinical benefits of the drug. And if the therapy was not effective, the FDA still has the right to take the drug out of the market. And then also, this is how Aduhelm or aducanumab is now it's being used. It's usually an infusion over 1 hour, and it needs titration. And the idea of the titration to minimize the risk of ARIA. And also the FDA still did state that these patients throughout the course of treatment will need to be monitored by frequent MRIs. So there has to be an MRI at baseline, then an MRI after the 6th infusion, before the 7th, before starting the higher dose. And also, before at the end of 1 year and going forward as long as the patient remains on receiving Aduhelm or aducanumab. But, so we have the drug approved, but it wasn't an easy sale as everybody expected, because first, as I said, the accelerated approval program was controversial because the behavioral data were not convincing. And we started seeing, big academic medical centers, including Harvard, that declined to offer aducanumab to their patients on premises in their hospitals. And then this was followed by the VA system, the Veterans Health Administration declined to offer the drug. Then we start seeing even the drug was rejected in Europe. It was even voted to be rejected in Japan. And then really what killed it in terms of clinical practice was the CMS decision, which is the Center for Medicare and Medicaid Services, which basically covers the costs for treatment for elderly in the US. They declined to cover the cost of the treatment, and they said we will only cover it if these patients were enrolled in a clinical trial, which is a very big barrier to do in clinical practice, especially if these physicians are not affiliated with the medical center or they don't have the experience of conducting clinical trials. They will not be able to enroll patients in the to get coverage. So right now, aducanumab is still on the market. It's available, it's not been taken out, but its clinical use is very limited because of lack of convincing evidence about the behavioral benefits and lack of coverage, because still this is a costly drug for many patients. So, but if somebody is willing to cover the cost, they will still be able to receive it. Though, again, as I said, the clinical and clinical practice, the use of aducanumab or Aduhelm has been very limited. But aducanumab is the first one, and maybe perhaps the first drug that comes may not always be with the best drug. We have seen this with HIV drugs. The first drugs that came with the protease inhibitors were not the best, but they opened the door for other and better ones to come. And that's what we are hoping also with aducanumab. It did open the door for other antibodies that we will discuss that appear to be perhaps more promising than aducanumab itself. And the first one we will discuss is donanemab. That is now in clinical trials and by Eli Lilly. And it's similar. It does go after the different regions of the beta amyloids. Through in this one, they are specifically targeting the N3 pyroglutamate. They think that this is somehow will reduce the formation of these oligomers that can aggregate together and forming the clumps that eventually, as we said, will trigger the cascade of events that lead to neuronal death. And, in single dose, in phase 1, they found that this drug or this antibody was well tolerated in healthy individuals. And they conducted a trailblazer trial, the phase 2 trial. And again, we saw that these patients had significant accumulation of beta amyloid at baseline. And then, but the trial was a small number of trials. This was a phase 2, what we call proof of concept, having only 272 patients relative to what we have discussed with aducanumab. There were over 3,000 patients in the 2 trials. But, they found very interesting also observations or results with their antibody. And when we look at the plaque, the accumulation of amyloid plaque and phosphorylated tau, as you see here, significant and profound and rapid depletion of beta amyloid as early as 6 months. After 24 weeks, there is a profound reduction in beta amyloid. Not just in beta amyloid, also they found significant and profound reduction in tau. So this is an antibody that not only targets beta amyloid, there is also evidence that it can target the second causing reason for Alzheimer's, which is the accumulation of tau. So basically, you may say you're hitting 2 birds with 1 stone. This antibody is capable of reducing both amyloid plaque aggregation or accumulation, as well as significantly lowering the phosphorylated tau. And then they found something interesting that they are coming with, that perhaps we don't need to treat these patients all the time, indefinitely, or for years on monthly basis with this antibody. Perhaps it's enough to treat these patients until you reach a point where there is complete clearance of beta amyloid, and then you can stop the treatment and just follow these patients in their assessment of their cognitive and behavioral functions. So an approach like this will be interesting because it will be first cost effective, because these patients will only be treated for 6 months, or whatever amount of time that is needed to reach complete clearance of beta amyloid. And then there will be no need to continue following the patients with sequential MRIs, which will also reduce the cost and also will reduce the risk of ARIA. So these patients will not have to be exposed to these high levels of the antibody on monthly basis for years. So that's an interesting approach that we still have to see if this can be a valid approach to just clear beta amyloid in the brain, and then in this case just follow the patients in terms of the assessment of their behavioral symptoms on the different scales that we discussed. In the trial, they use different scales, as you see here, and we saw significant improvement in different behavioral symptoms using different scales, the IADRS, the CDR, the ADAS-Cog13, the functional. All of them achieved significance range between 21 to 39% on the different scales. So though, and that tells us one thing also, though we did see a significant improvement on the behavioral scale, it did not actually correlate exactly to what we have seen with the depletion of beta amyloid of the brain. Donanemab is perhaps the most effective in its ability to clear beta amyloid, but let's say if we get a reduction close to 90%, we were expecting to see an improvement of behavioral symptoms of, let's say, 50% or higher. And the 50% was even the cutoff for Lilly, and as the target they wanted to achieve, they could only achieve 32 to 32% to 39%. So it was less than was anticipated. Nevertheless, this is considered a positive outcome, being able again to show that depletion of beta amyloid was effective in translating improvement of the behavioral symptoms, though to a lesser degree to what is expected from what is seen as a result of the profound depletion of the beta amyloid by donanemab. The safety and tolerability, it was also very comparable to what was seen with other antibodies, and so there was still risk of ARIA around 27%, but only 8% had infusion-related reactions that did require either to terminate the treatment or to intervene in case that the ARIA edema becomes more symptomatic. But still, nevertheless, these patients, regardless of the antibody that they will be receiving, I think there will be always recommendations for careful and close assessment through sequential MRIs for any signs of ARIA to prevent their deterioration or becoming more severe. So now Lilly is conducting a bigger trial that will use around, the 1,500 patients. The first trial was very small in Nature, 276 now. So this will give us a better idea about the real benefits of aducanumab in a larger population of patients. Interestingly, because they found that their antibody is capable of reducing both tau and beta amyloid at the same time, they have in their inclusion criteria not that the patient should not only show abnormal accumulation of beta amyloid, they also want to show that they have intermediate or high burden of tau. So to validate their approach that it is preferable to have an antibody that is more effective against the two hallmarks of the disease. This may eventually translate into significant or improved outcomes on the behavioral scales. And so the Trailblazer 2 is ongoing now, and we will know the results hopefully in the first quarter of next year. The second antibody that is in development is called gantenerumab, and it's being developed by Roche. And again, it shared with the other antibodies the ability to reduce accumulation of beta amyloid in the brain. And they provided us with data up to 2 years. If you look at this patient 3, for example, at baseline, the significant and profound accumulation of beta amyloid. And then as we go into after 1 year, there is a reduction and more continuous clearance of beta amyloid after 2 years. So that's something I think is shared by all these antibodies, their ability to reduce accumulation or the beta amyloid burden in the brain. What they disagree on is their ability to translate this reduction into improvement of the behavioral symptoms of the disease. Gantenerumab now is undergoing 2 big phase 3 trials. It's called the Graduate 1 and the Graduate 2. And the interesting thing, there are 2 unique things about the gantenerumab trials. First, it's going for a longer period of time. It's going for 27 months. The previous 2 trials with donanemab and with aducanumab, they were 18 months. So this will give us even a better indication about the long-term benefits, if any, with this monoclonal antibodies reaching more than 2 years. Then the second option, or the second advantage, it's going to be subcutaneous. And this can also be of an advantage, especially if it can be given at home by a caregiver. For patients still, for Alzheimer's patients, they need to go, if it's an IV, they have to go to the hospital. There are always logistic issues in terms of transferring patients and also in terms of scheduling of patients and, being able to have somebody to correctly establish an IV line, especially in the elderly, which can be more challenging compared to younger patients. So definitely having a subcutaneous formulation for Alzheimer's to be able to administer the drug by a caregiver will definitely provide a significant convenience in this regard, as long as the efficacy will be comparable to what is reported with other antibodies. So we will know the results of gantenerumab actually by the end of this month. There is a big meeting in San Francisco about the clinical trials in Alzheimer's disease, and I think the results will be reported there. So it will be interesting to see the outcome of this one. The last one is called lecanemab. And that's another drug that is being developed, or antibody, by Biogen and SI. And as we discussed, again, similar to what was reported with all other antibodies, the ability of this, the antibody to dose dependently, as we see here, reduce the levels of beta amyloid in the brain after 18 months of treatment. So again, it follows in the same footsteps of other antibodies that were developed for such purpose. Just, last month or in September, and the end of September, actually, Biogen and SI announced the results of the Clarity trial, which was really received positively in the field by clinicians and caregivers and patients, because the trial, at least what we know about right now in a press release, that the antibody was able to improve the symptoms of or slow the decline in cognitive functions in Alzheimer's patients at 18 months by 27%. The interesting thing here is we'll see that the p-value was highly significant. This perhaps is the highest p-value I have seen in any clinical trial for Alzheimer's. Not just on the primary endpoint, there were also they were successful in meeting all the secondary endpoints that looked at other domains other behavioral tests that look at domains of cognition, executive function, as well as the one that looks at the daily functional activity. They will all met with high statistically significant results. Again, there was also significant reduction in amyloid levels, and the ARIA incidence was within expectations. So all these are positive data. We are going to know more about the true clinical data in the upcoming meeting, but at least at this stage, lecanemab looks very promising as an option to consider going forward. We just have to see what will be the exact clinical data, and there is, potential FDA decision on the drug that will come in January of next year. So, we are moving ahead in the right direction in this regard. They are also conducting other trials. What we have, the 345 study, which will, in this regard, is going to go for 4 years, which even will give us a much longer time frame to evaluate the efficacy, safety, and tolerability about this drug on longer terms. The only limitation of lecanemab, actually, this drug needs to be given now in the clinical trials that they have conducted bi-weekly through an IV infusion. And if I said that even monthly infusions can represent as a logistic barrier in terms of scheduling of patients and making sure that these patients will receive their infusions on monthly basis, I think having a drug that can be, that needs to be given bi-weekly can represent a bigger challenge. Though if the benefits are there, definitely this will be something that we have to work around. But also, Biogen did recognize and aside that this can be a logistic barrier. So right now they are developing a subcutaneous weekly formulation of lecanemab. It's in late stages of clinical development. And perhaps by the time lecanemab is approved and is available to patients, maybe the subcutaneous formulation will be available too. They don't need to conduct clinical trials with the subcutaneous. All what the FDA asked from them is actually to provide data for bioequivalence of formulations, and this can speed up the process of having subcutaneous formulation available for patients in the near future. So not just, the beta amyloid, there are also the monoclonal antibodies directed against tau. And as we see, there are 3 of them, though these are still early in development at much earlier stages so far. And also we had one trial with the somarinimab that was not truly successful. The results were not as clear as we have seen with aducanumab and the other monoclonal antibodies against beta amyloid. But still, that's something that is in the pipeline, though I see all the focus right now on these beta amyloid antibodies, and these will come next. And we have to, the focus really the attention on the other antibodies, though they still be in the pipeline and may, come sometime, though there is still some time to go to validate the efficacy, safety, and tolerability of these antibodies. So we come to the question that I proposed in the beginning: immunotherapies for Alzheimer's disease. Are they ready for prime time? And the answer will be close, but not yet. You can say even close, but no cigar. We have come a long way in the development of these therapies, but still we have not crossed the end point. We have not crossed the finish line. But we hope right now with this exciting data from the Clarity trial, with the anticipation of knowing the results of the Graduate 1 and the Graduate 2 trials, with the ongoing trial, the Trailblazer 2, with the donanemab that is still ongoing, that at the end we may be able to finally cross this finish line. We may be able to actually finally provide an effective therapy, provide a treatment that can alter the course of the disease, provide a treatment that would improve the quality of life of patients, of Alzheimer's patients, not just the patients, but also the caregivers. I think this is a task that we are all striving for, and the near is close. We did not reach it yet, but I do anticipate perhaps in the next few years, we will be able to tell our Alzheimer's patients, now finally, we have something that we can help these patients. We can slow down the progression of the disease, improve their quality of life. And I think that's a goal that we all try to achieve in the near future. So this is my question and this is my answer. And I thank you all for your attention. Thank you very much.
Thank you, Professor Tarazi. This was, wow, a wild presentation. All these maps are floating and coming our way in the near future. It is very exciting, and I think it's actually a very, very good thing that the first one has been marketed already. I have a question. Are there any post-marketing studies yet? Are there any preliminary results?
Not yet. This was just approved last year. And, trials in Alzheimer's is not like in schizophrenia and depression where you will need 4 to 6 weeks to validate if the drug is working or not. As you see, the trials are 18 months and, at least, and then trials even going longer than 2 years. Let's not forget, if you see a trial that is 18 months, actually, the actual trial will be 4 years maybe. Because between the time that is needed to enroll patients and meeting the criteria of inclusion, and then doing the trial, and then analyzing the trial, and sometimes they have to reopen the trial to enroll more patients. So that's why, when they say a trial in Alzheimer's can take 4 to 5 years, that's very logical, and so that's why it's still very early. The drug was just approved last year. Biogen is still conducting trials, the phase 4 confirmatory trial, but still we will need for years before we know a true outcome of these trials.
Thank you. Is there any idea what the discrepancy of results between the two trials of Biogen?
I don't, they did not really actually provide a good answers. Some days they said, well, we think that the ENGAGE trial that failed, these patients were not exposed for the highest dose for the longest period of time. They think right now that really to achieve benefits with aducanumab, these patients need to be exposed for the highest dose for a longer amount of time. But, I can't tell you that their explanations were convincing enough because it did not well received in the field as the evidence that these academic hospitals were not convinced that there is significant value of the treatment. And this was followed by the VA health system. And then eventually the CMS decision was the final straw that killed it in terms of the use of clinical practice. But, if we give FDA credit in this regard, that they did approve it and they said this can open the door for other ones. I do think if aducanumab was rejected out flat that time, maybe this would have killed other antibodies that were in development, that people would have given completely up on the beta amyloid hypothesis as a target of interest to go after. But, as I said, with the case with HIV and other diseases, even Duchenne muscular dystrophy, there are other drugs that came along the same mechanistic line. And hopefully, if aducanumab is not the best one, it ushers the road or paves the road for other and better ones to come.
Thank you. Thank you. Exciting area. Are there any questions from our participants?
It's a little bit off psychiatry, but I felt this topic is a very hot topic right now, and the expectations and people are looking at it in terms of a major breakthrough for a major unmet need. Alzheimer's is becoming, who doesn't know or have someone in the family, unfortunately, because the biggest risk factor is always age, and we are an aging population. So it's becoming part of, growing up to be able to face such a devastating disease.
Well, it may be a bit slightly off psychiatry. However, we psychiatrists do see lots of the behavioral disturbances within Alzheimer's and the dementias. And it will be interesting once they get to become more or less mainstream approaches, medication approaches, to see them working for the behavioral disturbances or the other than Alzheimer's type dementias, the frontotemporal dementias, the Lewy body. So
at this stage, absolutely. At this stage, there is no evidence that the aducanumab, for example, can be used for FTD or Lewy body dementia, and it's still risky to try it without an evidence. And I absolutely agree that there are psychiatric disturbances, and they can be concerning. And in many instances, they can be the main reason why patients are sent to nursing home or long-term care facilities where families no longer be able to deal with the patient. And among that, we have 3 main psychiatric disturbances: the psychosis in Alzheimer's, the agitation, and aggression. And there are right now drugs in the pipeline specifically trying to address these subset of symptoms. of the disease. They are not considered disease modifying in this regard, but at least until we reach the stage of, having disease modifying therapies, may very well, they still be useful for patients. And again, for psychosis, we have a drug called pimavanserin that is being looked upon in Alzheimer's psychosis, as well as another one called CAR-XT. For agitation, we have drugs like Rexulti or Auvelity, a new antidepressant that was just approved and in clinical trials for agitation. So this is another major unmet need, but I agree that perhaps these disease-modifying therapies will be addressed not just the core symptoms of memory and cognitive impairment, they will also be able to address and improve the behavioral disturbances that are associated with the disease as a result of its progression.
Hopefully. Now, I have a question in front of me, which reads, thank you for this interesting presentation. This is a very interesting prospect for the treatment of Alzheimer's. Do you think the lack of improving behavioral symptoms is because the inflammation caused by beta amyloids led to neuronal damage already? Would starting an individual on drugs like these earlier, I beg your pardon, like if they have a genetic predisposition for early onset Alzheimer's, for example, help improve the outcomes?
We are recognizing that the benefits of these therapies appear to be more beneficial. The earlier we intervene, the better will be the outcome. And there is right now an approach towards, what we call MCI due to Alzheimer's disease, or mild cognitive impairment due to Alzheimer's. The problem, is finding these patients. How are we going to find them? We don't do screening tests to be able to identify patients at that early stage. But I think perhaps going forward, as these more and more therapies become available, that these interventions become more successful, we may very well start, implementing policies or recommendations for screening. We have recommendations for screening for colonoscopies and mammograms at specific age. So perhaps we should start screening for cognitive functions at specific age. The reason we don't do this right now, because will be the value of screening someone with no effective therapy? When we have recommendations for mammograms or colonoscopies, there is always an intervention at that stage with colonoscopy. For example, if they found a polyp, they can intervene immediately, and the same for mammograms. So the idea here, once we have a therapy that can complement the screening, I think this may very well become a standard recommendation at a specific age to identify these patients at such an early stage before even what we call the asymptomatic stage. And perhaps at that stage, these therapies may become more effective and can significantly alter the course of the disease. But we want to take it one step at a time. Let's first get to the finish line, get these drugs approved for mild Alzheimer's. Then we can start, diversing our targets and looking at earlier stages, and perhaps why not even consider if there is evidence that may be still useful for moderate patients with moderate stage of the disease.
Fantastic. Well, are there any more questions or points that the audience would like to raise?
This is your last chance.
This is your absolutely last chance. Before I thank very, very much Professor Tarazi for a wonderful tour of current pharmacotherapy, promising new pharmacotherapy, immunopharmacotherapy for Alzheimer's. And I would like to thank you all for being here on behalf of Professor Fountoulakis and myself and the WPA. Thank you very much for joining us. And I hope it has been as enjoyable for everybody as it has been for myself. Thank you, Professor Venizelos. Thank you, Professor Tarazi. Thank you for your time. It's been wonderful to have you tonight with us. Thank you.
Thank you.
Thank you very much. Thank you.
Thank you. Take care. Bye-bye.
Bye.